Welcome back to the deep dive. Today we are definitely putting on our orthopedic thinking caps. We're diving deep into a condition that, well, it frustrates residents, it challenges attendings, and it really plagues our high-demand athletes.
It really does.
We're talking about adult osteochondritis dissecans,
Yeah.
or AOCD. We've gone through a huge stack of sources for this one, everything from classic radiographic findings all the way to the absolute cutting edge of biological repair.
Yeah, and it's a fantastic set of material. I think the best way to tackle this is almost like we're in a preoperative conference. You know, you as the resident, me as the attending.
I like that.
Because the core struggle with AOCD, it's not like fixing a ligament or reducing a simple fracture. We're dealing with a systemic failure of the entire osteochondral unit itself.
Absolutely. So let's try to unpack this. At the most basic level, OCD is a pathology where the subchondral bone and then the articular cartilage right on top of it, they detach from the parent bone underneath.
Yeah.
Sort of like a piece of the foundation and the floor tile on top of it just start peeling away together.
That is the perfect image. I always think of it as a peeling sticker. The resonance definition is spot on, but the consequence of that peeling, that's what drives our clinical anxiety.
Right.
When that detachment happens, you lose the support of that subchondral bone, which is, highly vascularized and metabolically active. So the cartilage, that smooth, pearly white cap, is just left hanging there.
Vulnerable.
Completely vulnerable, hyper susceptible to shear forces. And once it starts to fragment, you've introduced mechanical instability into a closed system, and that just dramatically accelerates degenerative change.
And the cause, the etiology, is just so frustratingly elusive. It's always labeled as multifactorial. You see repetitive microtrauma, acute injury, ischemia, even genetic links or issues with ossification.
It's never one thing.
Never. It's always this catastrophic confluence of factors.
Which makes prevention almost impossible. But what's so fascinating is, despite not knowing the exact cause, the location is so consistent. The knee is the dominant joint, and 80% of those lesions are squarely on the medial femoral condyle, the MFC.
80%. It's an incredible statistic.
It is. And then you get maybe 15% on the lateral femoral condyle and a tiny 5% in the patellofemoral joint. And we should be specific. The classic site is the lateral aspect of that MFC, that high-stress zone.
So the prevalence, around 15 to 30 cases per 100,000, that really underscores why we need a clear plan for this.
We do.
And that brings us, I think, to the most critical fork in the road. The one thing that dictates the entire treatment algorithm. And that's the separation between juvenile OCD, or JOCD, and adult OCD, AOCD. We really can't stress this enough.
Correct. You have to know the skeletal age. It's everything. JOCD happens in kids, skeletally immature patients with open growth plates. They still have this vast biological potential, tons of vascularity in the epiphysis.
That can heal.
A lot of the time, they can heal themselves, with non-operative management. But AOCD, that's after the growth plates close. The adult joint has, it's lost that innate healing capacity.
So once an adult becomes symptomatic with an OCD lesion,
the course is almost universally unremitting. The cartilage just can't regenerate. So we're jumping immediately to intervention. Fixation, drilling, restoration. It's the distinction that guides whether we reach for crutches or a scalpel.
which makes the clinical picture and, our diagnostic roadmap so essential. If non-operative treatment is basically off the table for the adult, we need a really high degree of confidence in our diagnosis and, critically, in the fragment stability.
Absolutely. When these patients come in, the complaints are often pretty vague at first. Mechanical pain, swelling, made worse by sports or high-impact activities.
But then it changes.
It does. As we go from a stable in situ lesion to one that's partially or fully detached, the symptoms change. The red flag, the thing you're listening for, is the onset of mechanical symptoms.
Clicking, catching.
Exactly. Clicking, catching, popping, or outright locking. Those are the classic signs that a loose body, or at least a hinged, unstable fragment, is getting in the way of normal joint mechanics.
And on the physical exam, the findings can be all over the place. You might see chronic signs like quad atrophy or decreased range of motion from guarding, or maybe just a simple joint effusion.
Very variable.
But the classic test, the one that points us right toward that typical MFC lesion, is the Wilson sign.
The Wilson sign. It's one of those orthopedic gems, isn't it? It's a sign that just reflects the patient's own protective mechanism.
How so?
Well, when a patient with that classic lateral MFC lesion walks, they often have this antalgic gait where their leg is held in relative external rotation.
And they're doing that on purpose, subconsciously.
Right. They're trying to decrease the contact pressure between that specific sore spot on the medial femoral condyle and the medial tibial eminence. They're unloading the lesion. A positive Wilson sign is very suggestive. It's not enough for a diagnosis, but it sure tells us where to focus our imaging.
But as you said, no physical finding is definitive. We can't go to the OR based on a positive Wilson sign alone. Confirmatory imaging is mandatory.
Mandatory. We need to see the lesion structure, the status of the subchondral bone, and the stability of the fragment. And we always start with plain films, but, you can't be lazy with the views.
A standard AP and lateral just won't cut it.
Not at all. We need 4 views. Standard AP, the lateral, and the merchant view for the patellofemoral joint. But most importantly, especially for those posterior lesions, we need the flexion weight-bearing AP.
The tunnel view. And you can see that in, figure 28.1 in the source material.
Exactly, the tunnel view.
So why is that tunnel view so crucial?
Because on a standard AP view, especially in extension, the posterolateral aspects of the MFC are totally obscured by the tibial spines.
I see.
The tunnel view, you take it with the knee flexed, it opens up that intercondylar notch. It lets us profile those posterolateral MFC lesions way more effectively. If you skip the tunnel view, you could easily miss a big symptomatic OCD lesion.
And what are we looking for on these x-rays? What are the radiographic hallmarks of AOCD?
We're looking for distinct borders. The lesion itself often appears as an area of osteosclerotic bone, so it's denser, whiter than the surrounding bone, and it's separated from the epiphysis by a high-intensity radiolucent line.
And that lucent line is the key.
That's the key. That's the cleavage plane. It shows us the bone is trying to detach, or has detached, and the body is reacting with this thick, sclerotic rim right around the separation zone.
Okay, so the plain fills give us the location and the general picture. But when we move to actual planning, the gold standard, the surgeon's roadmap, is the MRI.
The MRI is, well, it's non-negotiable for preoperative planning. It gives us this unprecedented view into the whole osteochondral unit. It shows us not just the size and location, but the quality of the subchondral bone. How much edema is there, the state of the cartilage, the degree of separation.
And you can see a great example of that in figure 28.2.
Yes. All those elements are crucial. A big lesion might look fixable on an X-ray, but the MRI might show severe bone edema, telling you the fragment is basically biologically doomed, and that pushes you away from fixation and more toward restoration.
And what I found really compelling in the sources was the predictive power of MRI for lesion stability.
Mm-hmm.
I mean, we're talking about 4 specific criteria that, when they're present, offer up to 97% sensitivity and 100% specificity.
It's incredible.
That level of certainty is just so rare in orthopedics.
It is. It lets us go into the OR knowing pretty much exactly what we're going to find, no big diagnostic surprises. And we should probably break down those 4 T2 weighted criteria because they all come back to one thing, fluid tracking. And fluid is the kiss of death for stability.
Okay, so let's start with the cleavage plane itself.
Right. So criterion 1 is a thin, high signal intensity line, and the key is it's 5 millimeters or more in length, right at the interface between the fragment and the bone.
So that's synovial fluid getting in.
Exactly. Joint fluid is getting into that cleavage plane. It acts like a hydraulic wedge, forcing the fragment out and preventing any kind of biological healing.
Okay, so number 2, we look at the subchondral bone itself, right under the fragment.
Yep. We're looking for a discrete, rounded area of homogeneous, high signal intensity, again, 5 millimeters or more in diameter, directly beneath the lesion. This is the bone edema. It tells us the surrounding bone is reacting severely to mechanical stress. Significant edema suggests that even if we fix it, the bed itself might be struggling.
And third, the surface of the cartilage.
We check for a focal articular surface defect, 5 millimeters or more in width. If that smooth cartilage surface is breached, the fragment is exposed to massive shear and compressive forces, and the prognosis just got a lot worse.
And that breach is probably what lets the fluid in the first place.
Often is. And then finally, the ultimate indicator of failure.
The 4th sign.
The 4th critical sign. A high signal intensity line that traverses the articular cartilage and the subchondral bone plate and extends right into the lesion. This means the fluid signal has gone all the way through, confirming the fragment is either detached or hinged, and, it's ready to fail catastrophically.
You see any one of those 4.
You have to treat it as unstable, period. You plan for fixation or restoration.
And these criteria feed right into our staging systems, like what we see in Table 28.1 for osteochondral fractures. It gives us a common language.
Exactly. It's a logical progression. Stage 0 is normal. Stage 1, you see signal changes, but no definite disruption. The first signs of trouble. Stage 2 is critical. You've got high-grade signal, a breach in the cartilage, but the fragment is still stable when you probe it.
In Stage 3.
Stage 3, you've got that thin, high-signal rim behind the fragment. That's the fluid, so it's partially detached. And Stage 4 is the worst-case scenario. A loose body, completely detached, floating around in the joint, causing that classic mechanical locking.
Given how much we relied on MRI pre-op, what about post-op? The sources noted some uncertainty about its value after surgery.
That's the real difficulty. Post-op MRI is great for looking at things non-invasively, assessing deep structures without doing a second-look arthroscopy, but reliably predicting a clinical outcome, how the patient feels and functions years later, just based on a post-op MRI, the data gets pretty murky there.
And this is where MOCART comes in, right?
Yes, MOCART, the Magnetic Resonance Observation of Cartilage Repair Tissue Score. It's an attempt to standardize how we look at these things post-op. It grades several parameters: how well the defect is filled, integration with the native cartilage, signal intensity, the subchondral bone.
But the reviews, like the one from Went and his group, they show that while it's a great research tool, the correlation between a high MOCART score and a patient's actual long-term function, it isn't always there.
It's not consistent enough to hang your hat on for prognosis. Our primary trigger for post-op imaging is still clinical. If the patient is symptomatic, we go looking. If they're not, we're happy.
Okay, so let's pivot to prognosis. If we confirm AOCD in a symptomatic adult, the natural history of the disease is what really pushes us toward timely, aggressive action.
Yeah, that mechanical stress is just relentless. It's why high-impact athletes, basketball, soccer, anyone with high compressive or rotational loads on the knee are predisposed. The trauma causes these little microfractures, interrupts the blood supply to that subchondral bone, and can lead to a vascular necrosis.
And when the bone dies, the cartilage on top loses its foundation.
It's an unavoidable failure at that point.
And we should remember that most AOCD comes from JOCD that just never healed, right? Though some cases are de novo.
That's a critical point.
Yeah.
And the spontaneous healing in JOCD, it rarely happens in that classic lateral MFC location, which has the worst prognosis anyway. So if that fragment is still loose when the growth plates close, it's now an AOCD lesion with a clock ticking toward arthritis.
So what does that ticking clock lead to if we just, watch it?
Well, the historical long-term outcomes are pretty sobering. They really demand we intervene. Linden's landmark study followed patients for, on average, 33 years. They found that AOCD patients developed symptomatic OA a full decade earlier than the general population.
A full decade.
Yeah. And Twyman's group looked at JOCD patients decades later, and 50% of those knees showed radiographic OA at 34 years. And crucially, the progression to OA was directly proportional to the size of the original lesion.
So the bigger the peeling sticker.
The faster the whole surface degrades, exactly.
Which brings us to conservative care. And you mentioned earlier for the adult, it has a very limited role.
Limited is a generous word. For a stable lesion in a kid, yes. Immobilization, partial weight bearing, activity mod, anti-inflammatories, that's the standard. You give the body a chance to heal. But for an adult who is symptomatic, conservative care is basically a path to failure.
Let's use that ceramic plate analogy again, because I think it perfectly explains why.
It does. Think of adult articular cartilage like a fine china plate. Smooth, mutable ceramic. If that plate cracks, that's our OCD lesion, it does not, under any circumstances, knit itself back together. It's avascular. It doesn't have the cellular machinery for true high-aligned cartilage repair.
And the bone underneath is a bad foundation.
A terrible foundation once it's been compromised. So if we just immobilize the patient and tell them to rest, we're basically putting a cracked china plate back in the cabinet and hoping it fixes itself.
It won't.
It will not. You need active intervention. You need surgical superglue or a specialized patch. That's why the moment we confirm a symptomatic, unstable, or even potentially unstable AOCD lesion in an adult, we move straight to surgical management. The biological engine for repair is gone.
All right, so let's jump into the OR. The surgical goal is clear. Enhance healing, fix the fragment, or replace the tissue. And looking at the decision algorithm in figure 28.3, the choice is, well, it's a nuanced blend of factors, isn't it? Age, demand, lesion size, location.
And the fragment's biological viability. The pre-op setup is standard but meticulous. Supine, thigh holder, knee flex to 90. And we always start with a thorough examination under anesthesia.
Checking for other injuries.
You have to. You never want to miss a concurrent ACL tear or a meniscal injury that could compromise your whole repair. Only after that do we proceed to diagnostic arthroscopy.
And during the scope, the probe becomes our most important tool. We're relying on Gould's classification from table 28.2 for that intraoperative staging.
Gould's is crucial. You use that probe to assess the exact degree of stability. Stage, I might look fine but feel soft. Stage 2, that's where you find a detached fragment, often hinged like a trapdoor. Stage 3 is completely detached but still in the crater. And stage 4 is the loose body. That real-time feel dictates what we do next.
Okay, let's talk about the most radical option first, just taking it out. Excision and loose body management. Indicated only when the fragment is deemed unsalvageable, right? Comminuted, avascular, deformed.
This is one of the most controversial areas in the field. Excising a small, irreparable fragment seems logical, remove the problem. But the long-term data after just fragment removal is often highly disappointing.
Yeah, even if the short-term results for small lesions, like less than 2 square centimeters, can look okay.
Exactly. The long-term failure rates from groups like Anderson and Pagliani are pretty compelling. A lot of their patients who just had an excision ended up with poor or fair results years down the line.
And we have to ask why. Why does just removing a small fragment lead to failure?
Because when you take out that osteochondral fragment, you expose the sclerotic subchondral bone bed to all the mechanical forces of the joint. And that sclerotic bone is way too stiff. The cartilage around the defect, it just undergoes accelerated breakdown. You haven't fixed the foundation, you've just exposed it to more damage.
So this evidence really pushes us toward aggressive preservation.
It does, but let me challenge that from a practical standpoint. Yeah. Preservation means fixation. It means guaranteed hardware removal, a longer, probably more painful recovery. If the goal is function, isn't there an argument that for a small, non-weight-bearing lesion, an easier excision with a quick microfracture might be better initially, even with that long-term risk?
That's a really valid clinical trade-off. It highlights the whole nuance of the AOCD decision tree. Our authors here, and I think many surgeons, would say you should avoid excision whenever possible because of that long-term OA risk. If we're forced to take out a large, weight-bearing MFC fragment, we're already planning for an early restoration procedure, like an OAT or ACI. But if it's a tiny incidental loose body we have to remove, then yes, maybe you lean toward benign neglect and just educate the patient and watch them closely.
But the default should always be, if you can save it, save it.
So if we choose preservation for a stable or maybe just biologically unstable lesion, our first move is drilling, trying to reestablish that blood supply.
Yep. The mechanism is simple. OCD involves ischemia. Drilling creates these vascular channels, conduits to get blood flow, growth factors, maybe some stem cells, to the affected region to promote healing across that cleavage plane. We use this mostly for fragments that are stable to probing but show those fluid signals on MRI.
Those palatable fragments.
Those palatable fragments. And we have two ways to do it. Antegrade versus retrograde.
Antegrade is the easier path, right?
Good.
Straight through the cartilage.
It is. It's the one you'll learn first. You do it from the joint space with K-wires or drill bits. It's fast, accessible, but the biological cost is significant. You violate the articular surface and that defect fills with fibrocartilage, which is less resilient.
Whereas retrograde drilling avoids that violation completely.
Correct. But it's technically demanding. You enter the bone behind the lesion outside the articulating surface, and you penetrate the fragment without ever breaching the cartilage. You preserve that beautiful, mature hyaline cartilage. The challenge is just precision. You need a C-arm or specialized ACO guides to make sure you're targeting that cleavage plane precisely without knocking the fragment loose.
And that technical challenge is real. The sources cite a failure rate up to 20% when you're just using 2D fluoro to target a 3D lesion.
I mean, that's basically like trying to thread a needle in the dark, right? It's why the future looks so promising for things like 3D image-based navigation. CTEC and his group showed 100% accuracy using ISO C3 technology. It gives you 3D reconstructions intra-op.
But what about the prognosis for drilling in adults? Louise's group showed a pretty stark reality. 71% healing in JOCD versus only 25% in AOCD.
That 25%. That's why drilling is primarily a salvage procedure in adults. But if the fragment is stable, a Gould stage 1 or 2, it can work. Edmonds' group showed 75% healing in stable lesions, using that more protective retrograde approach. But the key takeaway is always that patient age is the single best predictor of success.
So, your clinical preference?
For a palatable but grossly stable MFC lesion, we'll try drilling. We'll try to do it retrograde, maybe coming in through the intercondylar notch next to the PCL or along the non-articulating borders of the femur. We just have to avoid violating that weight-bearing surface if we can.
Okay, so if the fragment is unstable, hinged, a goal stage 2 or 3-3, we're moving past drilling and on to reduction and internal fixation, or IF.
Right. Now we're bringing in the heavy metal. This is for when there's enough good subchondral bone underneath to support fixation. The goal is massive compression and absolute rotational stability. You can see some good examples in figure 28.4.
And the hardware choice is usually a cannulated screw. We see both constant pitch and, more importantly, variable pitch screws, like a Herbert or Acatrac.
Right. And you want to explain the advantage of that variable pitch design?
Sure. The variable pitch is biomechanically superior for compression. The threads near the head are spaced differently than the threads at the tip. So when you tighten the screw, that differential pitch pulls the fragment down into its bed, generating excellent compression across that cleavage plane.
And we almost exclusively use headless screws, so we can bury the head completely beneath the subchondral bone.
Which leads us to what the sources call the burial problem in figure 28.7. We have to recess that hardware to avoid causing more damage.
It's a necessary evil. If that screw head is proud, even by a fraction of a millimeter, it just acts like a grinding stone on the tibial cartilage. It guarantees accelerated OA on the other side of the joint, so we have to recess it. And you're basically trading a definitive second surgery for the highest possible chance of healing in a high-demand patient. It's a cost you have to accept.
So what's the plan for those metal screws?
If we use metal, we plan for their removal. The authors here like taking them out pretty early, at 8 weeks post-op. You do it to check healing and, critically, to prevent a situation where the fragment collapses a little during healing, which would make the hardware suddenly prominent and force you back to the OR anyway.
What about other options, like K-wires or metal pins?
Simpler, yes, but mechanically they're just not sound. They provide almost no compression, which is essential for bony union. They can bend, break, even migrate. They're just a poor choice for a weight-bearing AOCD lesion.
And bioabsorbable devices, the ones that are supposed to eliminate that second surgery.
They have a certain appeal, but they come with significant biological risk. The compression is questionable compared to metal. They can fracture. And more worrying is the degradation process can cause this foreign body reaction and aseptic synovitis. The patient comes in with a swollen, painful joint.
Weckstrom's group actually compared bioabsorbable nails versus pins in AOCD, and the finding was really telling. Nails, which give you better rigidity and compression, had 73% good or excellent results. Pins were only at 35%.
The mechanics won out. It shows you how important that stability is.
So the procedure itself for fixation is pretty rigorous.
It is. First, you hinge the fragment open, like peeling back the sticker, to expose the base. Then you have to meticulously debride and curette that sclerotic bed. That white, dense tissue has no biological potential. It has to go so you can expose bleeding, viable bone.
And after the debridement, you use microfracture awls or a K-wire to stimulate that bleeding.
The prerequisite for healing. Exactly. Then you reduce the fragment, get it perfectly back in its crater, anatomic alignment. Then you place your guide wire, over drill, and finally place the screw, making sure you get compression and that the head is recessed. We can see that whole process in figures 28.5 and 28.6.
And what if the fragment doesn't sit right, even after you've debrided everything, suggesting there's underlying bone loss?
Then you have to augment it. For large displaced fragments where there's a visible gap, you have to bone graft. We'll typically harvest cancellous autograft from Gertie's tubercle on the same leg. We pack that spongy bone into the defect to give immediate structural support, and then we finalize the fixation with our screws. That graft provides the solid foundation our hardware needs to work.
Okay, so that's fragment salvage. But once a fragment is gone, or if the defect is just too big for a primary repair, we shift to restoration. We're trying to replace the damaged tissue with hyaline, or hyaline-like cartilage.
Now we're moving from the hardware store to the biology lab.
And we start with the simplest form, marrow stimulation or microfracture.
The mechanism is fascinating. We use an awl to puncture the subchondral bone plate, creating these tiny holes to breach the vascular supply.
Which releases a flood of pluripotent stem cells from the marrow into the defect, and they form what's called a superclot.
Right. And that superclot then differentiates into repair tissue, but the critical point is what it becomes: fibrocartilage. And fibrocartilage is biomechanically inferior to native hyaline cartilage. It's less resilient, but it's better than an empty hole.
And it's only indicated for small contained defects, right? Typically less than 4 square centimeters. You can see that in figure 28.8.
Correct. And post-op is rigid. Strict non-weight bearing for 6 weeks, often with a CPM machine to help that clot mature into a smooth surface. But the durability is the issue, especially in adults. Gudis and his colleagues showed microfracture outcomes really declined after about 4 years, especially compared to OAT.
So it's a good initial fix for small defects, but you have to manage patient expectations.
You really do.
So if the defect is too deep or too large for microfracture, we move to osteochondral autograft transplantation, or OAT, sometimes called mosaicoplasty.
Right. This is where we transplant plugs of mature hyaline cartilage with the underlying bone from a low weight-bearing region into the defect.
The huge advantage is you're filling the defect with real hyaline cartilage and solid bone, so the short-term results are excellent. Miniashi and his group reported normal knee scores for all 20 of their OCD patients treated with OAT.
But the limitation is right there in the name: autograft. You're creating a donor site defect.
Exactly. Donor site morbidity is the main concern. We take these plugs from the edges of the trochlea or the intercondylar notch. But because you have limited supply and you don't want to injure the donor site, OAT is really restricted to smaller lesions, maybe less than 1 square centimeter, or you use it as a mosaicoplasty, patching a bigger area with multiple small plugs. Effective, but definitely capacity limited.
Okay, so now we're moving to the gold standard for large isolated defects up to 10 square centimeters, autologous chondrocyte implantation, or ACI, and this is a big commitment for everyone involved.
A huge commitment. It's a 2-step procedure, which automatically means more cost, more morbidity. Step 1 is the initial scope to biopsy healthy chondrocytes from a non-weight-bearing zone.
Then you wait 4 to 6 weeks while those cells are expanded in a lab. And then you have step 2, the implantation, which we see in figure 28.9. We meticulously prepare the defect, creating these nice vertical walls of healthy cartilage, debriding the base to healthy bone, and then we have to seal the perimeter.
Using a patch, right? Historically periosteum, but now more commonly a collagen membrane, sutured down, sealed with fibrin glue, and then the culture cells are injected underneath. It's a highly specialized biological process.
But critically, what about that deep subchondral bone loss, the hallmark of advanced AOCD? If the defect is deep, ACI alone is not enough, is it?
Absolutely not. For defects deeper than 8 to 10 millimeters, you have to do a concomitant or staged bone grafting procedure to rebuild the foundation first. And if you stage it, you have to wait a minimum of 6 months for that bone graft to incorporate before you can do the ACI. You can't put the chondrocytes on soft, unstable ground.
And if you do it all at once, you use that ingenious sandwich technique.
Exactly. The bilayer collagen membrane. You fill the deep defect with bone graft, then you put one layer of membrane over it to seal the bone. Then the cells are injected between that first layer and a second layer on top.
So you're creating a contained, stable environment for the chondrocytes to grow while the bone graft heals underneath. It's brilliant.
And the efficacy is robust, especially as a secondary treatment. The STAR study showed an 85% success rate at 4 years for ACI after a failed initial procedure. But Krishnan's group showed that significant drop-off for adult-onset patients, only 44% success, compared to 91% for juvenile-onset patients.
Which just reinforces the need for early, effective intervention.
Right. So finally, when the defect is just massive, bigger than 10 or 15 square centimeters, and there's extensive subchondral bone deficiency, we're left with the osteochondral allograft, or OA.
This is the only way to resurface those massive defects with mature hyaline cartilage and address the deep underlying bone loss, which is the core problem in AOCD. You can see a great example of this in figure 28.8.
We're using fresh donor tissue, fashioned precisely into plugs to match the defect, and then fixing them with screws. The key advantage is just scale. You can repair defects that would be totally impossible with OAT or too deep for ACI alone.
And the outcomes are really strong. Garrett reported a phenomenal 94% clinical success in AOCD lesions treated with fresh OA. Long-term, you see subjective improvement in 75 to 85% of patients. It's really our structural Hail Mary pass for the most complex cases.
Okay, so that moves us into the most exciting part of this, the future frontier. We need these next-gen techniques to overcome the limitations we just talked about. The 2 surgeries for ACI, the donor site morbidity of OAT.
And Khan's review gave us an excellent snapshot of what's coming. 5 novel techniques, all showing improvement in functional scores. We're really seeing a shift from just repairing the surface to truly engineering a complete osteochondral unit replacement.
Let's focus on that engineering approach. Biomimetic osteochondral scaffolding.
This is truly revolutionary stuff. It's a type I collagen hydroxyapatite nanostructure that's designed to perfectly replicate the healthy, 3-layered architecture of native osteochondral tissue.
And it's prefabricated.
Prefabricated, so it solves the donor tissue problem. And it's a one-step procedure which eliminates the ACI staging problem.
And that architecture is designed to mimic the 3 distinct layers of the natural joint, right?
Precisely. The top superficial layer is mostly collagen and nanocrystals for the smooth articular surface. Below that is a transitional layer of collagen and hydroxyapatite. And the deepest layer is mineralized hydroxyapatite with collagen, which acts as the subchondral bone substitute. It replaces both the bone and the cartilage, addressing the fundamental pathology of AOCD.
The other really promising technique is the single-stage cell transplantation, bone marrow-derived cell transplantation.
This is just efficiency realized. You leverage the body's own multipotent mesenchymal stem cells, or MSCs, to regenerate the tissue in a single sitting.
So walk us through that one-step process.
Okay, so it starts pre-op with a blood draw to create a platelet-rich fibrin gel for growth factors. Intraoperatively, you aspirate bone marrow from the posterior iliac crest, and you process it right there to concentrate the MSCs. Then you mix that concentrate with the gel and inject it into a hyaluronic acid membrane that you've placed in the defect.
The speed and single-stage nature are huge advantages over ACI. But does it really create hyaline cartilage? Or is it just a better fibrocartilage?
That's the million-dollar question. And the histology is very promising. Post-op analysis of the repair tissue showed a proteoglycan-rich matrix and, critically, type 2 collagen. And type 2 collagen is the hallmark of hyaline-like repair tissue, not just fibrocartilage. This method might really offer the best of both worlds.
Wow, okay, so this deep dive has clearly illustrated the incredible complexity of managing AOCD. We've gone from the classic Wilson sign all the way to biomimetic architecture.
And if we synthesize all of this, the central challenge is still that inherent biological deficit in adults. AOCD requires aggressive, timely surgical intervention. Drill it, fix it, or restore it the moment symptoms present, because that healing capacity is just not there.
And we're always pursuing those 3 goals: pain relief, functional restoration, and long-term prevention of secondary OA.
Exactly. And the treatment map hinges entirely on those specific decision points we talked about. Confirming it's AOCD, then rigorously assessing stability and size using those 4 MRI criteria and Gould's classification in the OR. Knowing where the peeling sticker is and how deep it goes, that's everything.
We have to move beyond just observation, and quickly.
We do. Now, here's the final provocative thought I want to leave you with as you think about how treatment in our field progresses. Given the strong, positive, long-term results we see with fresh osteochondral allografts for massive defects, and the enormous promise of these new biomimetic scaffolds, which offer a complete one-step biological replacement, how will we, ethically and practically, weigh early aggressive structural intervention using allograft or engineered materials against our continued attempts to save the native, potentially compromised fragment with fixation? I mean, for a young, high-demand athlete, are we morally obligated to attempt preservation, even if a replacement might offer a faster, more durable return to function?
A question that really moves us from the technical details of the OR right into the patient's entire future and the cost of innovation. That's a lot to consider as you digest this deep dive into AOCD.